knows when will it end. So they need to be taught these kind of things, and antenatal preparation will do a lot of good for a successful induction. The next thing that's important, whether it is for a normal delivery or for a labor companion or for induction of labor, is a companion in labor. What we do is we tell them to choose the companion in the antenatal period itself, and that companion attends the antenatal classes. So she's told what to do, help her go to the bathroom, help her walk around, massage her back, talk to her, give her fluids, and call us whenever she has a problem. It does a lot. Initially, 5-6 years ago, we worried that will the labor companion, go out and talk about what's happening. But in a labor room, when you are doing everything, I really don't think you need to worry. And women in labor have a fear of isolation. And we must understand that medical efficiency, which we are very good at. We are good at doing PVs. We're good at deciding what is the expected time of delivery. Is she going to be a high-risk labor? Is she going to not have a high-risk labor? They're very good at it. But humane considerations, we lack. It's not that we lack it. I'm sure we all have it. But it's just not possible in the labor room with one gynecologist or two gynecologists for us to sit with her, pat her back, talk to her, and reassure her. Maybe one or two kind words, but that's not enough. So we need to guarantee personal attention throughout labor, throughout the induction process, one-to-one, face-to-face. And for that, you need to have a companion. And mere physical presence is not enough. They need to help her around, make her walk, make her drink, make her eat, take her to the bathroom. Because the worst position in labor is lying down. Walking around and standing up actually helps. If you really think of it, the force of gravity, when she's lying down, the head is not going to be driven in that easily or that quickly. Whereas if she stands and walks around, the process is going to be faster. And remember, the companion in labor is a very low-cost initiative. All that you need to do is make her wear a clean set of clothes and come in. We actually tell them to pack the same kind of clothes which the woman wears, which is for us is a white munda or a white dhoti and a white blouse for the bystander as well. And we've seen that it shortens the duration of labor. We don't need to use much pain medication. We don't have a routine epidural system because we don't have enough anesthetists to monitor this. We found a decreased rate of cesarean, a decreased need for augmentation with oxytocin, a much better satisfaction with the birthing experience, and definitely a better bonding between the mother and the baby. What was the truth before we started all this? These were actually things that patients wrote out for us. No place is as lonely as the busiest labor room. There are hundreds of professionals running around. Doctors, nurses, house surgeons, interns, all of them are very busy, but nobody has time to talk to the patient. And they said every doctor looked after them, but they felt it was a little casual because they said in Malayalam that they were experiencing pain, but gynecologists told them, oh, you will have pain, don't worry. But that's not what they want to hear. Some of them actually said there was a sense of resentment because of a curt tone of voice. They saw a PV being done and a bloodstained glove, which was a little uncomfortable. There was they were in a delicate position and there was exposure with everybody watching. And very surprisingly, they wanted to know the results of their vaginal examination, which was never told to them. So we started off a whole lot of change as a result of all this. This is one of our consent forms in our vernacular, Malayalam, which tells them the consent for induction of labor. Here they know that it is not a 5-hour process. We take them through how many days it will take and how they need to be patient and what is the process they're going to go through, the need for cesarean and the consent for a normal labor. This will also include a consent for instrumental delivery as and when required. We have a protocol written down for our hospital, and this must be probably a thing which should be there for every hospital. This is a big medico-legal bat for us because we have it written down. It must follow standard guidelines. But if you have it written down, this is the thing that the hospital follows. So it's a 5-page document which is kept in the labor room. So even a greenhorn, somebody who's just started the process of interning or house surgeon just has to read this to tell the patient what to experience. Very often we are not able to provide written pamphlets to them. As you know, in a government hospital, there's always shortage of funds. So we have these boards that are put up outside the labor room. We just tell them, you please go read the instructions on induction of labor. It's given both in English as well as in Malayalam. And after that, she comes and signs the consent. This tells us everything that the patient needs to know, including how her hair must be plaited, how she must have a bath, what she must wear, how the companion should be, what he or she should do. It is all, and food, water, whatever they need to eat is not brought into the labor room, but they can walk out and have it. So very often I find that students, assistant professors, whoever it is in the labor room, find it very difficult to write an indication for induction because they're not sure if it failed or not. There are clear-cut guidelines to define what is a failed induction. A failed induction happens when you have not got regular contractions and no cervical changes after at least 12 or even 18 hours of oxytocin. That means you have done, if it was an unfavorable cervix, you used a ripening agent, then you started off the induction process with either a prostaglandin or the Foley, whatever, went to the maximum dose, then went to oxytocin, then or ARM followed by oxytocin. After the ARM, you waited 18 hours, nothing happened. Or if you've not done an ARM because the head was very mobile or for some reason, you gave her 24 hours of oxytocin, but still nothing happened, you say it is a failed induction. So you cannot say failed induction after giving her Pitocin for 3 hours or 2 doses of PGE1 or 1 dose of PGE2. There are clear-cut guidelines for these. You have to go to the maximum dose. I'll come to what the maximum doses are. So what are the agents that we have for induction of labor? Sweeping of the membrane is your stripping, as we call it. Quite a harsh word if you were to think of it, but and not very acceptable to patients because it's a little painful, but it does work. And remember, sweeping of the membrane is also a method of induction, and therefore I'm talking about the low risk woman, nothing will be done earlier to 39 weeks. We'll come to that later. If the cervix is really favorable, you could do a surgical method like an ARM. You could use one of the prostaglandins, either PGE1 or PGE2. Oxytocin could also be given after the ARM, preferably after the ARM, because we like the uterus to contract in an open space as opposed to a closed space that would happen if the ARM was not done. So the pressure buildup will be more, tachysystole may be more, and hyperstimulation and fetal distress will be more. So better to do the ARM if the cervix is favorable. Wait for an hour or two and then start oxytocin. Why? Because the ARM itself releases prostaglandins that could itself start off the process of labor. Wait for an hour. If nothing happens, then start oxytocin. The other thing which we very strongly believe and strongly advocate is the Foley catheter with or without the extra amniotic saline. Now, if you were to look at this slide, when you use the prostaglandin E1, these are all the yellow, blue, green, is all the different methods of or the different routes of induction. These are the hours. These are the plasma concentrations on the y-axis, and this is the x-axis has the hours. So in 100, sorry, not the hours, in the minutes. So in 100 minutes, which is roughly close to about 2 hours, you see that the peak levels with oral misoprostol are right down. By 200 minutes, which is about 3 hours, it's also almost baseline. So that it is important to recruit receptors in the myometrium and the decidua, both prostaglandin and oxytocin receptors, but the dosing frequency has also to be considered. Don't get worried about giving frequent misoprostols orally. Once every 2 to 3 hours is also good. It is physiological because once every 3 hours, your previous dose has now reached 0 levels. The The modified Bishop score should be part and parcel of our everyday practice. It is good to write it out where you do your and score it as 0, 1, and 2. And any score that is less than 6 is unfavorable. Anything more than that is favorable. And anything less than 6 needs cervical ripening and then induction of labor. I'm not going into the details of the modified Bishop score because we all know it. This is something that we insist. It is a seal. It's a very, very simple thing. It's a seal that is put before you enter your PV findings. So the date is given, the time is given, who has done, the PV is also given. Everything is there. Whether there's a caput, whether there's a molding, how is the pelvis. We tend, when there is a seal, we have to fill up these columns. We don't leave any of them empty, and that goes for a complete examination. So what we really recommend with an, let's now go to an unfavorable cervix. That is a cervix that is long, the os is closed, it is firm, it is posterior, and it's a rigid cervix. So I'm worried that my induction will fail. So I use a mechanical method. I can use a prostaglandin as well, but my worry about the prostaglandin is that it may start off labor contractions. I don't want labor contractions to start with an unfavorable cervix. I want the cervix to ripen, and then I want labor to start. And the ripening agent would be the Foley catheter. The vagina is cleansed well. The cervix is exposed on a sim speculum. The anterior lip of the cervix is held with a sponge holder. The Foley catheter is inserted into the cervix in a sterile fashion. You need to keep the plastic lining and cut off the tip and just put in the catheter. Then instill about 30 ml into the bulb and pull the bulb down. Pull it right down so that it sits at the internal os. And then tie this to the thigh, plaster it to the thigh, and leave it there. Along the infusion part of the catheter, you add about 200 ml of warm saline. Warm is not hot, body temperature, not cold, because you don't want her to shiver. You put extra amniotic saline, 200 ml, and leave her alone. The other method that you could use is there's a picture here. It's expensive. We have no experience with it. Is a Dilapan, is a hygroscopic osmotic dilator, which really will dilate the cervix and help you. Little bit more expensive. You have the double balloon catheters, the Cook's catheters, so as to speak. It costs 2,000 rupees. When you have the Foley, which costs 30, why would you use this? Just for the sake of completion, it goes into the cervix. One balloon is up, one balloon is down, and it opens out the cervix from top to bottom. The Foley does the same thing as well. So if you don't have the Cook, you needn't worry. The Foley is more than enough. Remember, the mechanical method is a low-cost method. It has less side effect. It only ripens. It doesn't really cause induction. And even if it causes induction, it does so a little later, at which time the cervix is more favorable. And most importantly, there is no hyperstenosis. So it is a good system. So when you put in the catheter, you just leave her alone for 24 hours. Very often we feel 25%, or the cervix is shorter by 25%. It's about 2 to 2.5 centimeters long. It's about 1 to 1.5 centimeters, 1 centimeter dilated. So you feel that the catheter will not remain at 30 ml. Don't worry, put in 80 ml. The bulb is inflated more, it's pulled in a little bit more, and it will dilate, it will soften. Then you worry, if I put in a Foley, isn't the woman uncomfortable? There's something hanging out. Is she going to complain? You talk about it to her in the antenatal classes. They are very comfortable with it. They always say, we don't want the medicine, we want the tube. So counseling is what matters. So what does the evidence say? Balloon versus, you can use the PGE2 gel also for cervical ripening. There is no difference in vaginal deliveries achieved in 24 hours. But definitely there is an improvement in maternal and fetal safety when you look at the balloon, because it doesn't cause any hyperstimulation. The prostaglandin gel will cause the cervix and the vagina to be vascular, softer. You can have traumatic PPH, and no difference definitely in maternal morbidity or in deaths. So when you talk about maternal morbidity, what are you worried about when you put the Foley catheter is the fact that does she have any vaginal infection? This is something you should check. By 37, 38 weeks, you should ask her, do you have any vulval itching? Do you have any abnormal discharge? If you have anything of that sort, speculum needs to be put in. No PV at 36 weeks, no PV at 37 weeks. You can put in a speculum, look at the discharge and treat it so that she's ready. If at all you need to induce her by 39, 40, she's ready for a Foley catheter. So as I told you, it is inserted under vision, totally aseptic. You need a set for this. You can't just put it anywhere and everywhere. Very sterile. You need a whole towel. You need to paint the area. You need to paint the vagina and put it under total asepsis because you're going into the uterine cavity, or rather into the extra amniotic space, which is inside the uterine cavity per se. The balloon can either be extended and distended to 30 to 80 ml, as I told you. You can keep the catheter even for 12 hours or for 24 hours. We keep it for 24 hours. We like to go slowly. After 24 hours, or when the catheter, sometimes the cervix dilates and the catheter falls off. That is not, you're not yet ready to start oxytocin. If you do a vaginal examination, the cervix is still unfavorable, you start with PGE1. We like to give PGE1 orally. We give 25 microgram every 2 to 3 hours, and we go up to 16 doses. That is 8 doses, 2 to 3 apart on the first day, the next 8 doses on the third day. Then we leave her in the evenings alone. On the fourth day, we do an ARM and start oxytocin. Fourth day evening, she sees the baby. So that is what is taught to her. It's a 4-day process. So you will not have calls saying, you know, my daughter has been there for 2 hours. She's been there for 24 hours. Nothing has happened. They all know it's going to take 4 days. You can use the PGE2 gel or the oral prostadin. You can use an intracervical preparation. As I told you earlier, we prefer the mechanical ripening because the cervical ripening intracervically makes it very soft, and sometimes in labor it can tear. But yes, it is an option. It can be used. You need to use something to ripen rather than starting off oxytocin. So you can use the 0.5 PGE2 Cerviprime gel manufactured by Astra, or if you're using a vaginal application, remember it's not 0.5. You need to use 3 grams because vaginal temperatures are higher. It gets degraded faster, so you need a larger dose. And when you give PGE2, you need to go to a maximum of 3 doses, 6 to 8 hours apart. And you wait for about 6 hours after the last dose and only then start oxytocin because you can get hyperstimulation. PGE1, I said we give 25 microgram orally every 2 hours up to 16 doses, or we give even 50 micrograms orally every 4 hourly. We used to give the 50, we've moved away from the 50. We are happier with the 25. If we give 50, we don't go more than 12 doses. With the 25, the maximum dose is 16 doses. Again, here I'd recommend that you just, this is something that I've taken out of the comprehensive abortion care guidelines by the government of India, just to understand how PGE1 acts. And this is for abortions, but I want you to extrapolate it to labor and see. Sublingual is the fastest. It has the highest plasma level and a long period of action. We don't want sublingual for labor. We don't want it to act fast. We don't want prolonged action. But it's very good for abortions. So it is the most preferred one for abortions. So if you want to prime your cervix for an abortion, give her the 400 microgram or the 200 microgram sublingually. Buccal is not as quick as the sublingual, but it's quick enough. That also has a prolonged action. It's good for labor. It's good for abortion induction, but not for labor induction. Vaginal is also quick, prolonged induction. Really, it is good for abortions, but not for labor. So what is good for labor is the oral, because it acts fairly quickly it acts for a shorter duration of time because it does get degraded. And remember, it is least recommended for abortion care because it takes longer times to act. We don't want things to occur fast. So we give an oral preparation, which is the ideal way to go about labor induction with oral prostaglandins. Next, it's not enough to think in labor only. When you choose the right fit, is not only the inducing agent, but also the time at which you will induce. So you do not cross 42 weeks. None of us will cross 41 if you were to cross your heart and speak the truth. We don't go beyond 40 plus 3 or maximum 40 plus 5. But definitely these like preeclampsia, GDM, twins, or IUGR will be indications to induce earlier. I'm not going into complicated inductions. In a low-risk woman, you should not induce before 39 weeks. We should all erase from our minds that babies are okay after 37 weeks. They're okay after 38 weeks. They are not okay. They have problems. Even the almost near-term babies have an increased incidence of respiratory distress and NICU admissions. There will be a time that comes in all our practice when you will be asked if there is a nursery bill of 1 lakh. Why did you induce my wife, or why did you induce me at 37 weeks? I never asked for the induction. So couldn't I have waited for 39? Would that have prevented my baby from getting into the nursery? So all your trials say nothing earlier than 39. I'll come to the ARRIVE trial. But I personally believe even if you wait 40 plus, it'll probably give you a better cervix. So what really did the ARRIVE trial said? It was a large randomized control trial which looked at elective labor induction in the low-risk woman, the low-risk nullipara at 39 weeks versus the expectant management in the same group of women. This was brought out in August 2018. And I must say, Pailisa has been telling us about this since 2003, but we never listened to him because we said, oh, 39 weeks, we are not going to do it. He has a cesarean section rate of about 12 to 14% by inducing at 39 weeks. But let me come to it. So this is a large, a very good trial, almost 6,000 women randomized, very, very robust, 41 facilities in the United States. And the numbers in both the groups were fairly equal, very robust to look at data. And what did the results tell us? That there was no difference in the primary composite outcomes. That means perinatal mortality and severe perinatal morbidity did not have any difference between 39 and expectant rates. Cesarean section, surprisingly, statistically lower in the induction of labor group, 18.6 versus 22%, which was a surprising thing for very many of us sitting in academics, and a lower rate of gestational hypertension and preeclampsia in the induction of labor, because we all know by 39 weeks, something raises its head. It's either hypertension, 100 diastolic blood pressure, and you start induction. So induce before it really starts. So lower rates of all these complications. But definitely a small increased need for neonatal, just a small amount of secondary apnea and a small amount of neonatal respiratory support within the first 72 hours, a little more in the induction of labor group than in the expectant management group. So I have put that in our state because I'm sure it will be there in Karnataka as well. Can we extrapolate this ARRIVE trial to all our centers? When I say all our centers, primary, secondary, tertiary level. I cannot extrapolate this to a tertiary level center where I do roughly about 1,400 deliveries a month. I cannot do that because even though we have anesthetists 24/7, we have a waiting list for cesarean sections, emergency cesarean sections. We have 2 theaters running 24 hours, but still we have problems. We have enough of personnel, but still there may not be enough personnel to monitor labor efficiently. So can you imagine the kind of problems you will have in a smaller setup where you don't have enough personnel, not enough CTG machines? You must be worried about this. And also you must remember that the few who would have gone into spontaneous labor, who would have actually delivered, will now have been induced in these women. So in a smaller setup where you have a one-to-one care, where you have the machines, you have the CTG machines, you have personnel to monitor, this is the best. Can I tell you that in very, very many of our centers in the periphery, The anesthetist goes off at 4 o'clock. After 4 in the afternoon, they have to call an anesthetist. Do you think that's an easy situation when you induce? Because every induced labor, be it at 39 weeks or 40 weeks or whatever week, is a high risk labor. So you must be careful. You must be able to think, yes, it's a good thing to induce at 39, but can my facility take this kind of a load? If you're inducing electively at 39, never before 39, due consideration must be given to go slow and to not make hasty decisions. So you must take her through the full induction, 16 PGE1s, 3 PGE2s, or 12 to 18 hours of oxytocin, or 24 hours with no ARM. And also keep in mind that the ARRIVE trial had an expectant management that went up to 41 weeks. None of us go up to 41 weeks. So we deliver much earlier. So maybe our cesarean section rates and our preeclampsia rates will be lower. We don't have any concrete data. But we also know that yes, by 41 weeks and definitely by 42, meconium starts to appear, which is worrying for us and definitely worrying for the neonatologist. The amniotic fluid also starts dipping by 36, but that does not mean that you induce everyone at 38. 39 is good enough. And you have special situations that for induction of labor, like for example, very many of us in Kerala, we don't induce our previous cesarean sections, but I'm sure there are institutions that do it, and I appreciate them for doing it. Previous cesarean with an intrauterine death, what do? In these, prostaglandins are dangerous. So here you must use a Foley catheter, or you can, I'll come to it later, you can use Mifepristone in these situations. PPROM or PROM, you must induce. You can't wait beyond, in the PPROM, not beyond 36, 37 weeks. And the PROM, not, you don't wait for much, in 1-2 hours if she's not in labor, you induce. So in those, you can't really use a mechanical method, but yes, you can use the prostaglandin. You start early, don't wait. But there are trials that are coming up now that you can use the Foley under extremely aseptic precautions, but do not instill the extra amniotic saline. Breaches, thanks to Hannah, we never really induce. We go ahead and do an elective cesarean. So Mifepristone is a very good drug. It softens the cervix. It's a good cervical ripening agent, but we really don't use it for term labors with a live fetus. But if you have an IUD, yes, with capital Y, 200 milligrams can be given. You give it to her orally, repeat it. You can repeat in about 12 to 24 hours, repeat one more dose. It's a very good cervical ripening agent. And then you start with whatever. If it's a plain IUD with a prostaglandin E1, or if it is not an IUD, if it is not a previous cesarean section, you can use larger doses. But Mifepristone can be given, and ideal when you have a previous cesarean with an IUD. So at the end of it, what is our stand on this elective induction? By and large, in the absence of any acceptable maternal and fetal risks, it is a dicey thing. But if you are doing it only after 39 weeks. So let's do these induction of labors right. Never before 39, first ripen, then use a prostaglandin, then use oxytocin, then ARM and then oxytocin, and then wait and deliver. Fourth day is the upper limit. So give enough of time. There are definitely hundreds of indications. This is all very, I would say, undergraduate level, but at the same time, you don't induce placenta previas, no abnormal lies, no prior classical cesareans or extended incisions, rupture uterus, full thickness myomectomy, also no. Gentle herpes, invasive carcinomas, and pelvic structural defects, we don't induce. Complications do occur with induction of labor. Failed induction is for us a very casual thing to write, but hyperstimulation can occur when you're using large volumes of fluid with oxytocin, smaller doses of oxytocin going on and on. I've not put oxytocin because I presume that we all know how to give it, but you don't need to start with 2.5 units. That's something that multis are given 2.5, primaries are given 5. No, start with 5 and do a geometrical progression, monitor the patient. You won't have water intoxication or hypotension. Tumultuous contractions can cause amniotic fluid embolism. You should be careful, and postpartum hemorrhage. So you must be very, very careful. This is my last slide, and something that I very strongly believe in. Childbirth, as there are, of course, a few male exceptions here, but very many of us have gone through this. It's a very unique event. Women are very vulnerable at that point in time. We need to deal with them more friendly, more carefully. And we should really consider ourselves fortunate to share this kind of time with these mothers. And it should provide a sense of profound and lasting satisfaction, both for us and for those mothers, and which we as doctors or midwives or nurses should actually consider ourselves fortunate to share this experience with them. Thank you so much.
Thank you very much, Dr. Sangeeta. It was excellent, as lucid as possible. And you have clarified so many things very, very clearly. And as I said earlier, this is a day-to-day topic. I'm sure most of them have been benefited by this. I would request Dr. Bharati to conduct the question and answer session.
Dr. Sangeeta, that was a very nice session, very practically. You have put across the points that are so simple for us to follow, and very, very emphatically, repeatedly, you have been telling, do not induce before 39 weeks. I think this should be the, can you please do that? This is the take-home message that all of us need to take. And the other thing which was very impressive was the consent and the antenatal counseling. I think this is where we are lacking in spite of all the protocols in place. The antenatal counseling to the woman and her family about what is normal labor, what time should it take, how long could be induced. These are some things which is becoming a forgotten art today. And the other thing is, you said 72 hours. I think somewhere down the line, we people are forgetting that labor is a long process, and we are just trying to induce them for 3 hours, 4 hours, and then taking up for them for cesarean section, saying it is a failed induction, which is absolutely not the fact. And that is the reason for the increased cesarean rate. And just before I take the questions, I would like to tell you that recently in Karnataka, we have had the health minister asking us to conduct an audit. And sadly, we have seen that the incidence of cesarean section rate is as high as 60%, 70% in some centers. So this is, I think, sometimes we need to act as obstetricians because it is a skill. Decision making is very important, and choosing the right case for induction is right. Then our cesarean sections will come down. And I think we have much to learn from you also. We will take this forward in future sessions. And before that, I will just take some of the sessions, some of the questions which are here. You have got a lot of appreciative messages in the chat box. And the first question was, there is for ruptured membranes, it's 12 to 18 hours to decide if induction is failed? That's what Dr. Sarumati wants to know. When do you call it a failed induction in case of a
Once
PROM?
membranes have ruptured, whether it is a PROM or an ARM, in 24 hours, that baby has to be out. If you look at the neonatal guidelines as well, after rupture of membranes, what the reasons to start antibiotics for the neonate is when you have crossed 18 hours after rupture membranes for delivery, or if you have had more than 5 vaginal examinations. That's something that I didn't write, but that is also something that every new PG that's coming in tries to learn a PV after rupture of membranes on a woman. That's really very sad. So if by about 9-10 hours, she is still not favorable, then I don't think you should be waiting that 18 hours. If she's well in labor and she has a good cervix, yes, 12 to 18 hours after ARM, you can wait. That is very clear. Both up to date as well as WHO says that you don't cross 24 hours.
But
restrict the amount of your PVs after you've ruptured membranes. Look at the labor progress by perabdominal palpation of the head, looking for contractions and a proper CTG.
Thank you. Dr. Sarumati has another question. How many doses of meso can you go on with?
Yeah, so what we do is Mifepristone is only given after the cervix is primed, and therefore we use the Foley. We start, I'll tell you how we do it. I don't know whether we're right or wrong, but our cesarean sections are low. We start at 6 in the morning. So 6, 8, 10, 12, 2, 4, 6, 8. 8 in the night, she has her dinner and goes off to sleep. If she gets into labor, well and good. So 8 doses on the first day, and that is 25 microgram orally. We keep her in the labor room. After 8 o'clock, when she has no contractions, we do a CTG. We make her have dinner, come back to us after dinner. We look at her once more and send her to the ward. Next day morning, so she sleeps. She sees her people, has a bath. We have general wards. So she has a bath. Next morning, she has to have a bath, wear a new set of white munda blouse, plait her hair in two, and come back to us at 6:30. And we start again. And we do the same thing for 8 more doses. And we leave her again. The third day, we start oxytocin and ARM. And that day, we deliver her. So I'm talking 16 doses of PGE1 given 2 to 3 hours apart over 2 days.
2 days. So there's another question from Dr. Dwarkanath. What is your experience with the mechanical agents like Dilaton and Ezai? Are they better than Cervicime and that correlation with the LSD? Cesarean rates? They want to know your experience with Dilaton.
I must say, Dr. Dwarkanath, that I have absolutely no experience with the Dilapan because our patients cannot afford it. But with the Foley, I will say that we have far better experience. If you look at our cesarean section rates we have the same experience with Foley and prostaglandins as the studies. The cesarean section rates are no better, but it is a much safer alternative. When I mean safer, no hyperstimulation, no vaginal tears, no colporexis, no sudden fetal distress, no running with your heart in your mouth to the theater.
So thank you, Dr. Sangeeta, for that excellent talk. And there's a question from Dr. Azra. In the previous LSTS with an intrauterine death, how would you induce them?
Yeah, so we try and get her previous record, see whether it was a previous classical, which is quite unlikely. But anyway, we have a record. We see if she's had any previous myomectomies, evaluate the risk, and then we give her Mifepristone, which is Ru486. We give her 200 milligram. We again tell her that your process will take not 3, but we may take 4 to 5 days. So you give her Mifepristone. 24 hours later, you repeat the dose again 200 milligrams, you repeat it, and then you do a vaginal examination. We are not against using a Foley with a previous cesarean section, so we put in the Foley as well. Most of them respond to this. If they don't, we do give them very carefully 25 micrograms of prostaglandin orally under very carefully guarded situations. We don't give them 16 like we do, but we give it about 3 hourly. We give about 4, 5, and then we start oxytocin. I think we have not had an instance of having to do an IUD. Yes, it's been ages since we've done one.
Dr. Sangeeta, but if it is an intrauterine death, still is there a necessity for Mifepristone to be given?
That is the thing. See, the Mifepristone primes the cervix. It doesn't really act as an inducing agent. With an unfit, see, the previous cesareans are likely to have a rigid rock-like cervix. The Mifepristone does work on the cervix.
Okay. So, Dr. Amanjit Kaur wants to know: have you used Mifepristone simultaneously with the Foley?
You don't really. The thing is, it may not be of you may not be doing any harm, but we don't like to do this polypharmacy. We go with just one and then wait. But yes, I do one thing. When I put in the Foley, my 16 and it has not fallen off after 24 hours. At the 18th hour, with the Foley in situ, I start my induction. Because I know I'm going to take a longer time. If it's fallen off, I know that the cervix is better. If it hasn't fallen off, I give her one PG, one along, and then I remove the Foley at the 24th hour.
What I generally do is we use the Foleys in the night. We introduce the Foleys in the night. Wait for her overnight, and next day morning we start tea. Because by the time, as you said, there's some effacement and dilatation,
Yeah.
and the Foleys follow spontaneously, and then we start the Mifepristone.
Yeah, madam, what happens in our setup is that night is the time the referrals come from the outside. So we like to keep the PGs alert for that rather than for our inductions.
So you don't
keep our inductions low in the night.
And there's one practical point I would like to ask you, because nowadays we see a lot of these pregnant mothers asking for a cesarean. They're not ready to wait. And waiting for 72 hours, how is the acceptability when you counsel them? Because many of them, when we tell them that you have to wait for 72 hours, they are quite, they're quite apprehensive, and they just say, no, doctor, please give a cesarean section. This we are seeing a lot in private practice.
I know. The whole thing will change with antenatal classes, because antenatal classes they love. And then you tell them, including how to sit, tell them to sit on the floor and have their food from 34 weeks so that their perineum gets stretched. They have a little bit of bending. And we also tell them that, if at all we need to induce you, the thing will take 4 days. You'll have a tube hanging out of your vagina, and we show them pictures. It's a video, it's on a PPT. And we also have the same thing playing as a CD in the antenatal OP on a TV screen. So they know that, if they come here, they're going to probably, if they have an induction, they don't complain. They don't. But yes, when you come out, when you do labor room rounds and come out, the mother will say, oh, my daughter's been there for 4 days. Nothing has happened. So I said, she's been there for 4 days. You've seen her in between and she doesn't have pain. So give us time. And we scare them with the Accreta for the next pregnancy.
Okay. So Dr. Sangeeta, I would request you that I will contact you later to kindly share us those view videos so that we can translate it in the local language and utilize it in our association.
Yeah. Everything for us, we are a medico-legally very strong state. So everything, and our women are very educated, even in the government setup. They're all, most of them have done their BA, but definitely at least till 12th standard. So they know. So everything is written. Every single thing is written. And we have a blanket consent when they come into the hospital, which is on the case sheet, which also involves taking pictures and photographs in an anonymized fashion for teaching purposes. Including that is given. Every aspect is, and they read it. And they are okay. They're okay. Yeah. But this induction consent, putting it up on the wall makes a big difference. Because everybody is reading it. Not just her. The mother-in-law, the father-in-law, the sister-in-law, everyone is reading it. It works.
Yeah, I think that's an excellent way taking this forward. We have our treasurer, Dr. Durgadas, who wants to ask a question.
Yeah. Yes. Dr. Sangeeta, yes. I'm a hardcore follower of Bailey, sir. I have spent a week there, not only learning vaginal hysterectomy, I have spent time in the labor room also. The protocols, whatever you have told, is excellent. Really, it is the best message you have given. That can be known by the number of participants. It has crossed 100, and there was a request for more and more participation. Really, I had to congratulate you for that.
Thank you so much. Thank you so much.
I have one or two doubts. One is, are you putting extra amniotic saline? Sir, Pelly sir has stopped it at that time, just at the time I went. Are you still continuing? Are you afraid of abruptio with respect to extra amniotic?
We don't have abruption, and we definitely use extra amniotic saline. We take the saline bottle and just keep, that's the only thing our sterilizer is used for. We just put it in the sterilizer so it gets a little warm, because we don't have a blood bath for us to warm the saline. So we just get it a little warm and put it inside. We use it routinely.
So along with the Foley's, saline is also instilled.
Yes. Okay. It works better. There is no abruption.
Second thing, meso you are giving orally. Second level you are giving.
Yes.
Is there any restriction about the food, because it varies? It alters the absorption of this thing.
No.
Are you advising anything about the food?
We have an ERAS protocol, which is the early mobilization, and we actually allow them to have liquids even 2 hours before a cesarean section.
Yeah, no, I'm concerned about the absorption of meso orally you are giving.
Yeah, but that is, though Mifepristone was marketed initially as a peptic ulcer treatment, it works. It doesn't give them acidity, and they are happy. They don't have indigestion or anything. We allow them to walk around. We allow them to eat. They have this misconception in their minds that they must have only kanji when they come to the labor room. But we keep telling them that that's not required. You can have soft diet, not anything heavy on your stomach, but they will have only kanji. And then the mothers will say that 4 days they've had only kanji. And most of them, when they deliver, they say they want to eat something fast because 4 days they've had kanji. But we give them anything to eat.
Dr. Sangeeta is wondering, when you induce them on labor, do you use electronic fetal monitoring, or it is just a manual fetal heart assessment?
We have a shortage of monitors as usual. We have 11 monitors in our stage 2, and we have another 8 in our stage 1, but there's always a shortage. So we rotate. All the high-risk labors will have the CTG continuously. When I say continuously, it's without the paper, because very often we can't afford the paper. But it is the monitor is looked at, and it is written on the case sheet. But the low-risk labors sometimes do have, if there is it's really busy at one point in time, we'll have intermittent auscultation. But all the high-risk labors will have a CTG recommendation. And anything that is, we have a morning after, like the morning after pill, we have a daily cesarean section audit the next morning.
Okay.
Every single day, 8 o'clock, that takes place. Each labor is analyzed. And the PGs have now, with the phones, they take the pictures of all the abnormal CTGs. If they've done a cesarean section for an abnormal CTG, the picture should come up.
Okay. I think that's excellent. I think now, thank you, Dr. Sangeeta. Before we propose the formal vote of thanks, Dr. Muralidhar Pai, any concluding remarks from your side?
So, thank you very much, Sangeeta, for not only for that excellent talk, but also for clarifying all the questions and all the doubts that we had. I'm sure everybody has appreciated that. So that's all I would like to say. And over to Dr. Durga Das for vote of thanks.
Thank you.
Thank you, Dr. Sangeeta man, for coming this evening and speaking to us. The numbers itself tells about the quality. Everybody was so enthusiastic about your talk, and there was demand for more participation, which we could not afford because we have purchased the Zoom only for 100 numbers. Once again, thank you very much.
Thank you very much.
Thanks, Dr. Muralidhar Pai, the chairman, our dynamic secretary, Dr. Bharti Rajshekar, thanking all the participants of today's evening. Thank you very much.
Thank you. Good night.
Good night.
Thank you and good night. Namaste, Dr. Sangeeta. Thank all the participants.